Thank you for visiting the Illinois Supported Employment Transformation Initiative website. The following recording is part of our IPS Training and Education online library. Visit our website to obtain free information and resources to promote employment in the behavioral health field.
Hello, and thank you all so much for joining us today for our presentation on mental health awareness, experiences of wellness and recovery. My name is Mary Shepler, and I'm currently an IPS trainer for the Illinois Department of Human Services Division of Mental Health. This slide also has my contact email, mary.schepler@illinois.gov, in case anyone would like to contact me after this presentation. IPS stands for Individual Placement and Support, which is the only evidence-based model for support employment services. The IPS model helps people that have been diagnosed with a severe mental illness find and maintain meaningful competitive employment in the community and in a position of their choosing. For the past 2 years, I have been incredibly lucky to be a part of an amazing team that works throughout the state of Illinois to expand access and education to this life-changing program. Before this position, I was actually an IPS employment specialist and IPS team leader myself for 5 years. So yes, this work is very near and dear to my heart. I love to talk about mental health awareness. I look forward to sharing with you all some of what we have learned, and certainly would appreciate the opportunity to learn from you all as well about your experiences in the field. So yes, I greatly appreciate that you all are here, so let's go ahead and get into it. Let's stand up to stigma and talk about mental health awareness. That is what we're here for. We want to open up this topic and conversation, open up a dialogue, which takes a lot of courage and self-evaluation, and I want to acknowledge that and thank everyone for being a part of that. This slide has a quote from John Lennon that hopefully puts us in an orientation state of mind. How can I go forward when I don't know which way I'm facing? Part of this training and what we have done in the past is when we go out into community partners and businesses, we want to talk about this. We want to start a candid conversation around what are words or phrases that you have heard associated with mental health conditions. Some of the things that you have heard either through the media or through your community, maybe even some things that you have thought or know someone else who may have thought or currently still do think. Some of the things that have come up are phrases that you may have experienced as well. We've heard individuals talk about going crazy or associations with danger or people that are dangerous. So the question is, when we look at these messages, is where do we get these messages from and what are they there for and how do we begin to start to change them? So let's get into some definitions, discussions about stigma, conversations around common misconceptions. The dictionary defines stigma as a mark of disgrace or dishonor that is associated with a particular circumstance, quality, or person. So that's heavy, right? Certainly talking about a mark of disgrace or dishonor when really what we are talking about is an illness that people are impacted by and that the people are working towards recovery from. Also an illness that can impact anyone regardless of race, sex, age, culture, or economic status. This slide breaks down some different types of stigma and stigmatization that we will be talking about today. So when we're talking about public stigma, we're talking about discrimination when the general public endorses negative stereotypes. It can lead to a loss of services and rights. It can create rejection and create social distance. Also, there is self-stigma. This is when a person internalizes public attitudes and negative stereotypes when they agree to them and they apply them to themselves. This can often lead to a why try kind of mentality, and it can also lead to a loss of self-esteem and self-efficacy. And finally, there's structural stigma. This is discriminatory laws, policies, and community attitudes towards a particular group, especially minorities. As we continue through this presentation, I would like you to think about these different types of stigma and examples that you may have seen or even experienced in your work. So let's unpack some common myths about mental illness and mental health conditions. People that have been diagnosed with a severe mental illness are often dangerous and violent. Medications are the only way to treat a serious mental illness, and people who have been diagnosed with one needs to be on them for the rest of their lives. Mental health conditions always run in family, and you can tell if someone has a mental health condition. Some more common myths include people with mental illnesses are lazy and lack motivation. People don't ever recover from a serious mental health condition. Mental illness and intellectual disabilities are the same thing. People with a mental health condition should never drink or use drugs, and mental health conditions are relatively uncommon. So, I think this quote is really quite dynamic, and needs to be considered when evaluating some of the misconceptions that we just discussed. People that have been diagnosed with a mental illness frighten and embarrass us, and so we marginalize people who most need our acceptance. When what mental health needs is more sunlight, more candor, and more unashamed conversation. This is a quote from actor and mental health activist Glenn Close. And again, I really feel that this slide hits home with a lot of the things that we were talking about today. I'm also going to talk a little bit more further on about Glenn Close and the conversations around not only our own preconceived notions, but also where they come from, what role the media plays in this, the representation of mental health conditions in our society, and what role we can play in regards to reducing stigma, including combating discrimination with compassionate language. So to go back to definitions, what is a mental illness? A mental illness can be defined as a wide range of diagnosable psychiatric illnesses that impair a person's ability to think, feel, and behave in a manner that allows for optimum functioning in day-to-day life. Prevalence of psychiatric disorders. So the reason that we are talking about this for a second here is to discuss exactly what the prevalence is. How common are mental health conditions? This information comes from NAMI, which is the National Alliance on Mental Illness. Research shows that 1 in 5 people in the United States will be diagnosed with a major mental illness at some point in time in their life. 1 in 4 Americans have a first-degree relative with a major mental illness. Schizophrenia has a 0.5 prevalence worldwide. Bipolar disorder has a 2 to 3% prevalence worldwide. Major depression falls between 10 and 25%. Anxiety disorders falls in at about 5 to 8% prevalence, and substance abuse disorders comes in at about 10% prevalence. These numbers are of worldwide prevalence. In the United States, 1 in 100 or 2.4 million adults are living with schizophrenia. 2.6% or 6.1 million adults are living with bipolar disorder. 6.9% or 16 million adults live with major depression, and 18.1% or 42 million of American adults are currently living with an anxiety disorder. And again, all of these data and statistics are coming from the National Alliance on Mental Illness. Now we're going to move into a little bit more about diagnosis and creating a shared language, talking a little bit more about different mental illness diagnoses, signs, and symptoms. In order to talk about this, we cannot not talk about the DSM. The DSM stands for the Diagnostic and Statistical Manual of Mental Disorders. It attempts to codify and categorize psychiatric illnesses into distinct groups with specific sets of definable features. The Diagnostic and Statistical Manual of Mental Disorders, DSM, is published by the American Psychiatric Association, the APA, and it offers a common language and standard criteria for the classification of mental disorders. It is used or relied upon by clinicians, researchers, psychiatric drug regulator agencies, health insurance companies, pharmaceutical companies, the legal system, policymakers, and of course our own mental health care practitioners. The DSM is now currently in its 5th edition, the DSM-5, which was published on May 18th of 2013. The first edition was published in 1952, and since then revisions have incrementally added to the total number of mental disorders, although also removing those that are no longer considered to be a mental disorder. Really, as mentioned before, for this conversation, we are going to use the DSM as more of a dictionary, providing a common language for understanding psychopathology. So using the DSM as a guide, we're going to cover with some very broad brushes to begin to define some of the more common mental health disorders that we work with in the Division of Mental Health and at our local community mental health care providers. So we'll start with schizophrenia spectrums and other psychotic disorders, which are related to a disturbance in the thinking. This can also be described as either experiencing symptoms that others do not, or alternatively, not experiencing the world as is experienced by others around you, which can be described through positive and negative symptoms, which we're going to talk a little bit more on the next slide. Also, a real quick note regarding signs versus symptoms. So signs are what a healthcare professional or someone from the outside sees, whereas a symptom is what an individual experiences. So while the sign may be the physical manifestation or behavior of injury, illness, or disease, the symptom can be described as what the patient's experience about the injury, illness, or disease is. Ideally, signs are going to be objectively observed by others, whereas symptoms are subjective and can only be observed by the individual experiencing them. When we talk about bipolar and related disorders, we're talking about a disturbance in mood consistency. So bipolar 1 is a disorder that involves periods of severe mood episodes from mania to depression. Bipolar 2 also is a milder form of mood elevation, which involves milder episodes alternating with periods of severe depression. And then there's psychothymia, which is a disorder that describes brief periods of hypomanic symptoms alternating with brief periods of depressive symptoms that are not as extensive or long-lasting as seen in some other diagnosis. Depressive disorders are related to disturbances in mood. Under this area falls a major depressive disorder, dysthymia, which is also now known as persistent depressive disorder, PDD. It is a mood disorder consisting of the same cognitive and physical problems as depression, but less severe and with less severe but longer lasting symptoms. And also premenstrual dysphoric disorder is listed under this area as well. Just to also make a note of some of the changes that occurred with the new editions of the DSM, we now see a change between bipolar and depressive disorders. They were once all listed under mood disorders and now have been separated to the mood disorder and a mood consistency disorder. We have now learned that these disorders are no more similar than, for instance, bipolar is related to schizophrenia, so hence the change. So schizophrenia is often described in terms of positive and negative symptoms, which do not refer to good or bad, but to the type of experience. Positive symptoms are those that other individuals do not normally experience, but that are present in people that have been diagnosed with schizophrenia. This can include delusions, disordered thoughts or speech, tactile, auditory, visual, hallucination, one that's typically regarded as a manifestation of psychosis. A negative symptom, on the other hand, are a deficit of an emotional response or of other thought processes. This might include a flat expression or little emotion, a poverty of speech, an inability to experience pleasure, a lack of desire to form relationships, or generally a lack of motivation. So on this slide, we have listed just some of the possible positive and negative symptoms someone might experience. Hallucinations, delusions, disordered thinking, disorganized speech, maybe psychomotor agitation, bizarre dress or appearance, which could actually fall more into a sign rather than a symptom, depending on who is defining the bizarre dress or appearance. And paranoia would all fall under positive symptoms, whereas a negative symptom could include a blunt or a flat affect, an impoverishment of speech, experience of withdrawal and isolation, anhedonia, which is defined as the inability to experience pleasure from activities that are usually found enjoyable, for example, exercise, music, or hobbies, or social interactions, and elogia, which is a type of poverty of speech. It is generally a lack of additional or unprompted content that is normally seen in speech patterns. Slowed cognition and thought processes also fall into this category, as well as catatonia, which is a state of apparent unresponsiveness to external stimuli in a person who is apparently awake. When discussing anxiety disorders, we're talking about a dysregulation in psychomotor arousal, including panic disorders, generalized anxiety, social anxiety, and experiencing a specific phobia. Agoraphobia, which is a type of anxiety disorder, is one in which you fear or avoid places or situations that might cause you to panic and make you feel trapped. This fear is about either an actual or anticipated situation, such as using public transportation, being in open or enclosed spaces, standing in line, or being in a crowd. Obsessive compulsive and related disorders are going to also fall under anxiety disorders. Obsessive compulsive disorder, body dysmorphic disorder, hoarding disorder, trichotillomania, which is a hair pulling disorder, and excoriation, which is a skin picking disorder. Again, all fall into this category. Personality disorders are characterized as disturbances in personality formation. These are characterized by deficits in interpersonal relating, affect management, problem solving, identity, and impulse control. I want to be careful and to be very clear that we're not talking about someone who's being unpleasant or difficult to deal with in this area. What we're talking about is a long-term, pervasive, maladaptive pattern of relating to others and to the world, which can create incredible distress and impairment in major areas of life functioning. For trauma and stressor-related disorders, reactive attachment disorder falls into this category, which is a rare but serious condition in which an infant or young child does not establish healthy attachments with parents or caregivers. Post-traumatic stress disorder, which is also an anxiety disorder that develops following a frightening, stressful, or distressing life event. It is also known as PTSD. PTSD is characterized by intense fear, helplessness, and stress, which can greatly affect the functioning of a patient. Substance abuse and addictive disorders, substance use disorders. Just a note, abuse and dependence are now viewed as part of a singular disorder with a continuum of severity, relating also as a gambling disorder. Feeding and eating disorders, as well as gender dysphoria, fall into this category. A note on this one as well. Gender dysphoria used to be known as gender identity disorder. This shift is largely regarded as a very positive change in the right direction, considering gender identity disorder does imply that there is something wrong with those who do not conform or identify with their assigned gender. The diagram here on slide 19 is to demonstrate how psychopathology can, not always, but can coincide with addiction. When someone is experiencing both a psychopathology diagnosis as well as an addiction diagnosis, this is referred to as a co-occurring disorder. If one diagnosis is primary, which is defined as the condition that requires the most resources and care, then the second would be named and treated as a secondary condition. So now that we've gone through that, what are some advantages of diagnosis? For some, it can be helpful to have a name for all the myriad of symptoms that they have been experiencing. A diagnosis can also change the treatment approach. For example, we may understand or approach someone who has symptoms related to depression very differently than someone struggling with the negative symptoms of schizophrenia, even when the behavior, isolation, lack of motivation, limited pleasure in activities, it may look similar. Diagnosis is also a part of medical necessity, and without it, we as healthcare providers have no justification for providing mental health professional care. Diagnosis can aid understanding of what is behind certain symptoms and help to increase empathy. Understanding a diagnosis and related criteria can also enrich our understanding of a person, not just limit it, so long as we are mindful of the whole person. But with a diagnosis, there are also risks. A diagnosis can be used to label people, which in turn is used to stigmatize and marginalize people. People can be treated as if they are only their illness and not as a whole person. And finally, a diagnosis is just a small part of understanding of a person and the impact of illness and or other illnesses. Here's a quote by Carl Jung that I think is really helps to define this as well. Clinical diagnoses are important since they give a doctor a certain orientation, but they do not help the patient. The crucial thing is the story, for it alone shows the human background and the human suffering. People who have been diagnosed with a mental illness or illnesses are often impacted by feelings and experiences of powerlessness, hopelessness, and despair. Feelings of invisibility, worthlessness, stigma, marginalization, loss of personal control around one's situation, isolation, loneliness, not being listened to or understood. They are often faced with dealing with the cumulative effects of poverty, homelessness, trauma, illness, and also unresponsive systems of care. Research has also shown us that people with a mental health condition are more likely to encounter law enforcement than to get medical help during a psychological crisis. There are currently more people with mental illnesses in jails and prisons than in hospitals. They are regularly blamed for violence when in fact they are much more likely to be the victims and not the perpetrators of violent crimes, and as already mentioned, experience greatly higher rates of homelessness. So how do you know when someone has a mental health condition or a substance use problem? And the answer is that most of the time you don't, at least not without a lot more information. With that being said, there is a lot known about the course of mental health conditions, and they include that as many as 2/3 of people diagnosed with a serious mental illness get much better over the long term. One's current level of illness severity does not predict long-term outcomes. No one can predict who will get better and who does not. Access to rehabilitation services improves long-term outcomes, and a trusting relationship with at least one helper can have significant impact on outcomes. So now I would like to invite our guest speaker, who's going to share a piece of her recovery story on the next slide.
It's really good to be here today. I have worked in individual placement and support, IPS supported employment for those in mental health recovery in Chicago for 12 years. One of the many reasons that I like my job so much is I believe that work is a very important piece of recovery for persons with a mental illness. Maya Angelou is quoted as saying, "Nothing will work unless you do." I would like to share with you a little bit about myself. Before working in IPS supported employment, I mostly worked in outside sales, inside sales, and product training positions. Except for a brief 6-month period, I have been working full-time since college graduation. I believe that working was a very important piece of my recovery, and it still is. I attended college and graduated with honors. I went to graduate school and received a master's degree in broadcast journalism. During graduate school, I did a documentary on homelessness. I spoke with a homeless man who had a mental illness. I was 24 then. I never dreamed that I would soon face a mental illness too. I first started experiencing mental health symptoms when I was 30 years old. I have been hospitalized 5 times for mental health reasons. The final time was in the summer of 2000. In July of 2018, I will celebrate the 18th year of my being well, out of the hospital, and back to work. I can truly say that there is great treatment for people with a mental illness. And NAMI, the National Alliance on Mental Illness, says treatment works. My current psychiatrist has diagnosed me with schizoaffective disorder in remission. With a previous psychiatrist, I was diagnosed with schizophrenia. To treat my illness, I take an antipsychotic medication along with an additional medication to treat the side effects of the antipsychotic medication. I also take an antidepressant. Outside of work, I volunteered for NAMI as a speaker for 12 years. As a speaker on the NAMI Speakers Bureau, I help to educate different audiences that people with a mental illness can recover and live bright, productive, and meaningful lives. In addition, I am very close to my family. My brothers and their wives, my parents, my cousin, and my husband, they have all been very supportive. When I have been sick, they have been there to get me help. When I have been sick in the past, I have had 5 major symptoms going on. Symptoms including paranoia. I was fearful that people were following me and monitoring me. I believed there were hidden cameras in TVs and mirrors, that the phone was tapped and the room was bugged. If you remember the movie The Firm, where someone is living in a home where they are totally under surveillance, that's what it was like for me. I also experienced delusions. A delusion is a false fixed belief, where I believe something to be very true, but it was really false and a symptom of my illness. The delusion that I got pulled into was, in the area where I grew up, there was a lot of conversation about the mafia. So when I started thinking about who could be monitoring me and victimizing me, guess what popped into my head? The mafia. And psychosis, a loss of touch with reality. I'm sure you can appreciate if I thought I was being monitored and victimized by the mafia, that was a total loss of touch with reality. It was not true at all, but rather a symptom of my illness. I also have a little tendency towards depression and anxiety that I have to keep an eye on. I remember the dark days. In fact, I keep reminders of them. Now, my memories of the dark days serve as a reminder that I have a mental illness and I need to take my medication every day to correct the chemical imbalance that causes my thinking to be confused. As I mentioned, when I became sick and before I agreed to accept medication, I had delusional thoughts about the mafia. Trust me, I love my family, But one delusion when I was not taking my medication was I truly thought that my parents were in the mafia. I was over at their house one evening and I perceived them to be a threat to my safety and my 4-year-old niece. I left their house and went into their neighbor's backyard and dialed 911. The police came, and after questioning my parents, the police wanted to take me to the hospital. In fact, I thought the mafia had installed hidden cameras and bugs in my home and my car, and I thought they were monitoring me. In my delusional thinking, I thought I was working with undercover police officers, the CIA, and the FBI to shut down the United States Mafia. I came up with a plan to write letters to some very important people and mail them to the White House. In the letter, I explained that I was being victimized by the mafia and I was asking for their help. After a few months of mailing about 4,000 letters to the White House in many cities throughout 12 states, I got a visit at my home from a Secret Service agent. He showed me his badge, I invited him in, and we sat at my dining room table. He asked me, "Are you mailing letters to the White House?" I proudly answered yes. My name and address were on all the letters and envelopes. I even put my phone number on the letters. He then asked, "Why are you doing this?" I asked him if I addressed, stamped, and mailed a letter to President Bill Clinton in a United States post office, and if someone broke into the post office and intercepted and read the letter, what would the penalty be? He answered 5 years in jail. I replied that I thought I was putting a lot of people in jail for 5 years. He said, "Just please stop mailing the letters." And I did not mail any more letters. My paranoia caused me to consider taking my life when I thought that the mafia would torture me to a cruel death if they thought I was working with the police to try to send them to jail. I also came close to being harmed after I confronted and said some pretty harsh words to a man that I thought was in the mafia following me in a shopping mall. After I finished telling this man off, he threw me into a glass window of a coffee shop. Luckily, the glass window did not break and my neck did not break. I realized that it's very dangerous for me to be sick. I can get hurt. Now I'm doing great. I have a great job. I am very close to my family. I married 13 years ago to a wonderful man that I love very much. I shared with him while we were dating that I had a mental illness. I am looking forward to a celebration in July when I will celebrate 18 years of being well, out of the hospital, and back to work. I would like to cover 3 of the steps that I have found to be critical in my recovery as a person with the lived experience of having a mental illness. First, I believe the foundation of hope for recovery begins with building an excellent support system. My support system consists of my doctor, my therapist, and my family. I see my psychiatrist once a month. I also see a therapist once a month. I have learned that it's important for me to be open and honest and share my thoughts with my doctors. I believe a second step to recovery is that the person with a mental illness must understand that they have a mental illness and they must accept that they have a mental illness. A big turning point is when someone can understand and accept that they have a mental illness and get with the program. It took me 6 years of struggling before I came to understand and accept that I have a mental illness and get with the program. So as I mentioned, a mental illness did not hit me until I was about 30 years old. And as I mentioned, I really struggled for the first 6 years. I did not understand and accept that this was a condition that I would have to manage for the rest of my life. It was not until the summer of 2000 that I came to accept and understand that I need to take my medication every day and see my psychiatrist on a regular basis. And things really never got better on a permanent basis until I got with the program. I think that people with a mental illness have to accept that they have a mental illness. And in my case, I have to accept that I have to take medication for the rest of my life. That this is not something I'm going to get well from, like the flu or a cold. And that taking medicine for the rest of my life is okay. A lot of people with physical illnesses have to take medicine for the rest of their life. True, there are side effects, but you can work with your doctor on reducing side effects. I believe that you have to accept that, and this will play an important part in your recovery. So what does acceptance mean to me? It means that I have to be responsible and make decisions on a daily basis to continue my wellness. Acceptance can mean giving up or doing things that one really may not want to do. For example, I made the decision to no longer drink alcohol because my psychiatrist explained to me that even though I was only having 1 or 2 glasses of red wine a week, that we would have to increase my medication, and pretty soon the alcohol would cause my medication to no longer work. And when I think about decisions like whether or not I'm going to drink alcohol or take my medicine, I have to make a decision like, what's more important, a glass of red wine or my ability to pay my bills, keep my condo, keep my marriage, keep my job, take care of my family, and keep my happy little life? The answer is clear to me. I have to take my medicine, and I cannot drink alcohol. I have to take responsibility for myself and make decisions to continue my wellness. I think it's not easy at first, but after I got out of the hospital and started getting stable, I had to get up and get out of the house and reconnect back into society. It's not easy. You have a bit of a shattered image, and you have to rebuild your confidence. To really recover, you need to reconnect. A person with a mental illness has to connect back to their family, connect back to social outlets, and connect back to work. It is by understanding and acceptance that I have been able to stay well year after year. I believe a third step to recovery is to find employment. It's important to be realistic regarding the level in which you re-enter back into the workforce. You may be able to start back where you were, but you may also have to work your way back up. What's important is to get back to work. As a supported employment specialist, I help people in mental health recovery find employment. I know from experience how important work is in one's recovery. One of my psychiatrists explained to me once that work is very stabilizing for everybody. Work can provide structure, routine, social interaction, a chance to contribute to the community, a sense of accomplishment, self-confidence, self-esteem, a paycheck, and insurance. Let me break each one of them down because they are all very important in a person's recovery from mental illness. Structure. When you are at work, you have a plan for the entire day. A reason to get up, shower, get some breakfast, and off you go to work. Once you are at work, you have a plan for the morning, then lunch, and a plan for the afternoon, then home to dinner and bed, and it all starts again the next day. This structure is wonderful for people who have a mental illness. They have a reason to get up and get out of the house. Routine. It's important to have a routine, a schedule that you can count on to know what the day will look like. Social interaction. Research shows that one of the side effects of unemployment in the general population is alienation and being isolated from others. One of the great benefits about work is that it integrates one back into the community, and work takes us out of the house so that we can be around others. An opportunity to contribute to the community. I agree with a poem by the author Rumi. The poem says, "Everybody has been made for some particular work, and the desire for that work has been put in every heart." I think that almost everybody deep down really wants to work and contribute to the community. A sense of accomplishment. To do the job well is meaningful. To feel good about being a part of a team that is working toward a goal. To contribute and be a part of an organization is meaningful. Work can also help you rebuild your self-confidence and self-esteem. When someone with a mental illness gets well and looks back at times when they were sick, they can often have a shattered image, sometimes along with shame and embarrassment. To be able to have a place to rebuild their self-confidence is meaningful and helps to rebuild the person's often shattered image and allows the person to start feeling good about themselves again. Work can provide a paycheck and, in some cases, insurance. We all know how important it is to be able to pay bills and how good it feels to earn a paycheck for your work. I work full-time, but part-time may be better for others. It's important for a person with a mental illness to get back to work. I believe it is also important to have a diversified workforce, including persons who have a mental illness. According to NAMI National, 1 in 5 adults in America experience a mental illness, and nearly 1 in 25, 10 million adults in America live with a serious mental illness such as schizophrenia, schizoaffective disorder, bipolar disorder, or major depression. It's important for employers to provide a place for individuals who have a mental illness to reintegrate back into society and back into the workforce. A little support and encouragement can go a long way in making a powerful impact on a person's life. I believe that you take a negative and turn it into a positive. So I have grown as a person in my journey having a mental illness, and I believe that I am a better and more knowledgeable person because of it. I figure everyone usually gets something. These bodies of ours are not perfect. Whether a person gets heart disease, diabetes, cancer, cerebral palsy, epilepsy, or even neuralgia, and some people develop a brain disorder. Some people have a heart attack, and others have a brain attack. The message is that mental illness can be treated with the right medication to correct the chemical imbalance in the brain and with the right support of a team so we don't have to face it alone. So often through the media, we only hear the negative side of people who have a mental illness. But thanks to organizations such as the IPS team for the state of Illinois, community mental health centers, NAMI, and dedicated people like you who are willing to support these organizations, People with a mental illness can get the supports they need to live fulfilling and productive lives and contribute to society. People with a mental illness are people with great potential who, with the right treatment team, the right medication, and with understanding of their illness, can have hope for a bright future. As I have shared, treatment works for people with a mental illness. I would like to thank you for understanding that mental illness is just that, an illness, and it can be treated, and people with a mental illness, just like people with diabetes, can get treatment and recover and live a bright and productive life and contribute to the community. Thank you.
There are many treatments for mental health conditions, and we know these treatments will be best implemented when they include client-centered planning, shared decision-making, and when they are strength-based, including evidence-based practices. Some common treatments include pharmacological treatments or medications, antipsychotics, antidepressants, mood stabilizers, anxiolytics, which is an anti-anxiety drug, and psychostimulants. Other common treatments include counseling and therapy, CBT and DBT, which is cognitive behavioral therapy, which focuses on the development of personal coping strategies, and dialectical behavioral therapy, which is a therapy designed to help people change patterns of behavior that are not helpful, such as self-harm, suicidal thinking, or unhealthy substance use. Motivational interviewing, which is a directive, client-centered counseling style for eliciting behavior change by helping clients to explore and resolve ambivalence. Psychodynamic therapy is a form of verbal treatment that helps patients to find relief from mental or emotional stress and is similar to psychoanalysis. Also, case management or group work. Some additional treatments may include diet and exercise, yoga and meditation, homeopathic and herbal remedies, self-help and peer support, psychosocial rehabilitation or PSR, community integration, and of course, employment. There are lots of pieces and parts of recovery, and one that far too often gets overlooked is vocational rehabilitation. And hopefully that's part of the reason that you are joining us here today, is to help to change that, to shift our thinking to include employment as a standard of care and as an essential part of community integration. This quote, I think, really beautifully sums up the importance of the work that we do to create meaningful pathways to employment opportunities for individuals that have experienced barriers to employment. This quote is by Dr. Robert Drake, who is now currently the Vice President of the IPS Employment Center at the Rockville Institute, but he made this statement back when he was doing his research around individual placement and supported employment services as a researcher at Dartmouth University. It is totally clear to me at this point that there is nothing about medications or psychotherapies or rehabilitation programs or case management programs or any of the other things that we study that helps people to recover in the same way that supported employment does. I have a respected colleague who often talks about how the mental health system has changed over the past 30 years in regards to recovery, and how we are really shifting away from systems that keep individuals isolated and segregated from the general public. We have more understanding that people tend to stagnate when they're sheltered from real-life experience, and instead are moving towards treatments where individuals can learn, achieve, and grow through both failures and through success. We know that people who have been diagnosed with a severe mental illness can and do recover and can be supported by systems that value empowerment and self-management, commitment to progress, and a whole person approach. There are many ways to define recovery, and each one will be as unique as the individual experiencing it, but this quote is one that I especially like. Recovery is a deeply personal, unique process. It is a way of living a satisfying, hopeful, and contributing life, even within the limitations caused by illness. Recovery involves the development of new meaning and purpose in one's life as one grows beyond the catastrophic effects of mental illness. And this quote is by W. Anthony. The diagram on this slide shows the 8 dimensions of wellness, which is just an incredible tool that was created by Dr. Peggy Swarbrick. Some of the ideas around this include the fact that wellness is incorporated by many interconnecting dimensions that can all affect our overall quality life, as wellness directly relates to both how long we live and as how well we live. These dimensions include the first one, emotional, coping effectively with life and creating satisfying relationships; financial, satisfaction with current and future financial situations; Social, which is the developing a sense of connection, belonging, and a well-developed support system. Spiritual, which is expanding our sense of purpose and meaning in life. Occupational, personal satisfaction and enrichment derived from one's work. Physical, which is recognizing the need for physical activity, diet, sleep, and nutrition. Intellectual, recognizing creative abilities and finding ways to expand knowledge and skills. And environmental, good health by occupying pleasant, stimulating environments that support well-being. When we feel financially stressed, for example, maybe an increasing debt, we're going to experience an emotional stress or anxiety. And sometimes that can lead to physical problems, which can lead to illness, less effectiveness at work, occupational, and maybe even questioning our own meaning and purpose in life, which would fall into spiritual. When we're not working, occupational, we might lose some of our opportunities to interact with others, social, and we cannot get the quality of foods and medical care that we need to stay well, physical. And we may need to move to a place that feels less safe and secure, which would be environmental. Again, this is going back to focusing on a whole person approach and looking at overall wellness in regards to recovery. So what are some ways that we can help to facilitate recovery? We can help individuals to find meaning and purpose in their lives and help individuals fulfill valued roles and engage in a life in a community of their choosing. Helping individuals see themselves as more than just their illness or illnesses. Accepting that an individual's strong emotion and disagreements with us may be a personal opinion rather than a pathology. And also respecting an individual's personal view of their illness or illnesses. There are many things that we can do to aid recovery, including fostering a shared determination to get better, also an understanding of one's illness, taking responsibility and working towards management of the illness. For many, it's identifying the positive aspects of medications and or helpers, cultivating friends and family who are accepting and locating supportive health professionals. For some, the acceptance of medication. Optimistic attitudes are not something to be overlooked, and also always finding a way to decrease and dispel stigma in our society. Also, spiritual beliefs, whatever they may be, is something that many have found to be integral in their recovery process. So how do you talk to someone with a mental health condition? The same way you would hopefully talk to anyone you came encounter with respect, a genuine interest, a desire to understand, a listening ear, an appreciation for cultural differences, and a belief that people are doing the best that they can. This is some information that I came across recently on a training around the portrayal of mental health conditions in the media, and I thought this was just excellent and very relevant to what we're talking about today. Some of this information is pulled from the Depression and Bipolar Support Alliance, which is the DBSA, and it's all available on their website, www.dbsalliance.org, and it gives examples of how to combat discrimination with the use of compassionate language. They suggest to avoid distancing, use language that references people or individuals instead of quote-unquote them, those, or the mentally ill. To choose thoughtfully, to be mindful of the many negative phrases historically associated with mental health conditions that have become part of the common vernacular and that can be incredibly harmful. To portray people and discuss them realistically and really avoid sensationalizing. When we're talking about someone, to avoid showing a person only in acute episode or in shock value behavior and avoid emphasizing the most shocking and tragic aspects of a situation. To separate the person from the condition, to avoid reducing the individual to only their condition. Also, to not make assumptions. When we're referring to individuals as people living with or experiencing mental health challenges, we need to allow for personal choice. The DBSA acknowledges that individuals do have the right to terminology of their choice, but they do encourage a more wellness-focused language when possible. Also, to defy definitions, use of the term mental illness, it may imply a perpetual state of abnormality, whereas a mental health condition often presents episodic challenges. And then finally, accepting responsibility, doing our best to choose language that is accurate, respectful, and caring, understanding that we will all make mistakes, and while preferential terms have and will continue to change, it's always helpful to do your best to keep current on accepted vernacular, to try to always be mindful, and accept that we are all in the process of continual learning. Recently, I've heard some discussion around shifting language from trauma-informed care to healing-centered engagement, and even challenging language around the use of the word stigma rather than the term discrimination. The Illinois Department of Human Services Division of Alcoholism and Substance Abuse, DASA, has also just changed their name to the Division of Substance Use Prevention and Recovery, SUPER, in order to be in accordance with strength-based and recovery-oriented language. On this slide, we're going to talk a little about mental health first aid, which is a national program that teaches skills around how to respond to signs of mental illness and substance use for individuals that are in distress. A quick overview of this program includes assessment for risk of suicide or harm, listening non-judgmentally, giving reassurance and information, encouraging appropriate professional help, and encouraging self-help or other support strategies. Mental Health First Aid is an 8-hour course that gives people the skills to help someone who is developing a mental health problem or experiencing a mental health crisis. The evidence behind this program demonstrates that it does build mental health literacy, helping the public identify, understand, as well as respond to signs of mental illness. If you're interested in learning more about mental health first aid and training opportunities, please visit their website, www.mentalhealthfirstaid.org, for information on the training near you. It is trainings like this that shift the conversation from what is wrong with you to what happened. Some additional strategies to consider when a person is exhibiting distress are to demonstrate empathy and acceptance, to listen with respect while acknowledging and validating feelings, inquire about personal comfort, what do you need right now, or what can I do to help you, checking your tone of voice, your volume, and your body language, and also paying attention to cues and adjusting your responses accordingly. When interacting with a person who appears to be experiencing paranoia, it might be best to avoid eye contact. Stand abreast of him or her, as if facing a hostile world together. It sends a message of camaraderie and non-confrontation. When dealing with someone who is angry or agitated, listening respectively conveys understanding. Avoid asking too many questions or redirecting immediately. When responding to someone who seems to be actively hallucinating, we encourage you to speak calmly and gently inquire of what might make them feel more safe and more comfortable. A quick cautionary note, there are potentially many reasons or possible causes of odd or unusual behaviors, and automatically assuming that a behavior is a result of a mental illness is stigmatizing and erroneous. The Committee on Economic, Social, and Cultural Rights defines discrimination as something that occurs when an individual is treated less favorably than another person in a similar situation for a reason related to a prohibited ground. In other words, when a person is mistreated or regarded differently than someone else based on their circumstances. This is a resource that I recently came across and just love so much I wanted to share it with you all. Each year, the Substance Abuse and Mental Health Services Administration, SAMHSA, grants the SAMHSA Voice Awards. The Voice Award program honors people in recovery and their family members who are improving the lives of people with mental illnesses, substance use disorders, or both, in communities across the country to support in raising awareness and understanding of behavioral health issues. These awardees' stories of resilience demonstrate that recovery is real and possible through treatment and recovery supports. This award program also recognizes television and film productions that educate the public about behavioral health and showcase that recovery is both real and possible. The writers and producers of these productions give voice to people with mental illnesses, substance use disorders, or both, by incorporating dignified, respectful, and accurate portrayals of these individuals into their scripts, programs, and productions. The goal behind these awards is to highlight and educate the public about behavioral health. They have been doing this since 2013, and yes, it is just an incredible celebration of accomplishments made by individuals and the media in regards to representation and transparency. If you would like to look into past award winners, please visit their website, which is www.samhsa.gov/voice-awards. Something else that I think is so important about this is really just in regards to changing views. I had mentioned Glenn Close at the opening of this training, and she is just one of many public figures who has increased her presence as a mental health advocate. You know, many years after portraying the female lead in the 1987 film Fatal Attraction, Ms. Close opened up about her regrets as to how this movie contributed to the misunderstanding of mental illness. In an interview with CBS News, she stated, "I think as public figures, as entertainers, that we have the moral responsibility to only portray characters that if they have disruptive behavior or behavior that is negative, it has to be responsibly explained. I really don't believe we can say anymore that, oh, let's just make our person somebody mentally ill. That's really be easy because it plays into the stigma that people with mental illnesses are violent, and that is not the truth. Most people with mental illnesses are not violent, and most people who commit violent crimes do not have a diagnosis of mental illness. That is wrong, it is proven wrong, and it is immoral to keep that perpetrated. It is public statements like this that promote continual evaluation and involvement of our expectations around media and appropriate representation. While I'm sure that this is something that is deeply etched into the hearts of helpers everywhere, it is always a good reminder to ourselves and to others to always be kinder than necessary, because everyone you meet is fighting some kind of battle. On this slide, we have some additional resources for you, your teams, and for those that you serve. These are just a few among many, many, and this is in no way a comprehensive list, but it is just a sample of some services that are out there. There's a crisis hotline, which is the national hotline at 1-800-866-9600. The Chicago Area Service Office of Alcoholics Anonymous, which is 312-346-1475. The Mental Health Association of Greater Chicago, 312-368-9070. The Depression and Bipolar Support Alliance, 773-465-3280. The National Alliance on Mental Illness, which is 708-524-2582. And the National Suicide Prevention Lifeline, which is 1-800-273-8255. I just want to thank you all again so much for your time and for your work towards ending mental health discrimination. Accepting people for who and what they are and believing that they can do better is the key to supporting one's recovery. I had an individual that I had the privilege of working with years ago, and I just loved her personal mantra, and it was, I did the best I could today, and I can do better tomorrow. So yes, on that beautiful note, I would just like to thank you all again for all that you do, for participating in this brave conversation and for supporting recovery in Illinois. I also just want to thank you all for being somebody that makes somebody else look forward to tomorrow. Take care, everyone, and have a lovely day.
Thank you for listening. You can obtain additional recordings or download a transcript by visiting the Illinois Supported Employment Transformation Initiative website.